Hello, everyone. Welcome to the second session of our mini medical school, Bone Health Across the Ages. We are excited to have you here tonight, and we look forward to guiding you through our second topic in this series, tonight covering sports medicine, maintaining musculoskeletal health. My name is Ann Van Heest. I'm an orthopedic hand surgeon, and I am a professor and vice chair of education in the Department of Orthopedic Surgery at the University of Minnesota Medical School. The Department of Orthopedic Surgery consists of nearly 100 faculty members and affiliated physicians, and we provide orthopedic care through the M Health Fairview System, Health Partners, TRIA, Gillette, and Center Care. We are proud of our orthopedic surgery contributions to patient care, to physician education, and to cutting-edge research. We look forward to sharing our orthopedic knowledge with you over the next few weeks. I have three of my orthopedic surgery partners with me here tonight discussing sports medicine topics. We will begin the three presentations and follow that with a question and answer session. You can submit your questions to the panelists at any time using the Q&A box, which is found by clicking on the Q&A button on the bottom of your Zoom screen. Please note that this session is being recorded and will be available starting tomorrow on the Office of Academic Clinical Affairs YouTube channel. We will share the link to the recording with you by email. So today we have the privilege of speaking with a panel of University of Minnesota Department of Orthopedic Surgery experts about treating common injuries such as ACL tears, patellofemoral problems, rotator cuff injuries, and gain new insights into biomechanics and injury prevention strategies. So let's start with our first panelist. Dr. Alicia Harrison is our first panelist. She is an associate professor in our Department of Orthopedic Surgery at the University of Minnesota. She is also our orthopedic surgery residency program director. She is the Gopher team physician for women's hockey and in possession of 4 NCAA Gopher Women Hockey Championship rings. She is a surgeon who treats osteoarthritis, rheumatoid arthritis, rotator cuff tears, and her research interests include shoulder replacement, resurfacing, tendinopathy, impingement. Dr. Harrison, can you discuss with us shoulder injuries and health?
I would love to. Thank you, Dr. Van Heest, and thank you everyone for taking your time this evening to be with us and have a conversation about what we're passionate about, which is the musculoskeletal system and how we treat it. As Dr. Van Heest said, I am going to speak about the shoulder. This is really my focus. I will talk a little bit about why I chose this area to focus on for my practice. It's really a fascinating, I think, joint and part of our body to speak about. And we want to try to preserve the health of this joint through our decades of life. I don't have any conflicts to disclose for this talk. I am going to speak a little bit about the basics of shoulder anatomy because this is a joint that is really very unique in that way. And then I'm going to discuss a few of the most common shoulder problems. There are quite a number of things we could talk about, but we are going to focus on the most common. And as a hint, not all of these are due to a specific injury or trauma. Some of them happen for other reasons. And then I will speak a little bit on the most common shoulder treatments for these problems. So the shoulder is a little bit of a very special joint. Dr. Arndt and I have conversations about this, or Dr. Nelson, in comparing the knee and the shoulder. It's really very a unique joint because of its anatomy. And the anatomy in this area allows for really the most extreme range of motion. It's why we can, in a healthy joint, position our hand all the way over our head or out in front of us or behind us, reaching up our back or out to the side. And the reason that we can do this is because the shoulder joint is a ball and socket joint, and so is the hip, but we like to say that the hip is a ball in a socket and the shoulder is a ball on a socket. And the shoulder socket is really very shallow, and so that socket doesn't restrict range of motion, and that's why we can move our hand in space to such a degree because of this very special anatomy. We like to compare it oftentimes to a golf ball on a golf tee. It is rather similar in that way, just in terms of the bony shape. And that affects the mobility of the joint, but it also can lead to problems. As you might imagine, with a golf ball and golf tee, if you just touch it a little bit, it will fall off. But in the shoulder, increased stability is added by all of the soft tissues of the shoulder, the tendons, the muscles, of which there are many, the labrum and ligaments. And so this is an X-ray of the shoulder looking at it in a way that makes it appear rather similar to the ball and socket. And the reason that this joint is as unique as it is that all of those different parts of the anatomy, the bones, ligaments, tendons, and muscles work together in a healthy joint to allow or for this extreme function. And when those structures are injured is when there can be a problem. So the components of the shoulder anatomy are made up by realistically three bones: the collarbone, clavicle, the scapula or shoulder blade, and the shoulder socket is a part of that very interestingly shaped shoulder blade. And then the humerus or the upper arm bone makes up the ball of the ball and socket joint. And then the muscles include the rotator cuff, of which there are 4 muscles and tendons, the deltoid muscle, and then lots of other muscles, which we refer to as periscapular ones, which connect the rib cage to the shoulder blade and the shoulder blade to the arm bones. And then additional ligaments and then cartilage add to the structure and function of the shoulder joint. And this unique anatomy can be altered by injury in many different ways. And these pictures demonstrate a very large, a wide variety of things that we might need to do to try to improve or protect or address the function of the shoulder or injuries that can happen. And this is why really I fell in love with this joint, is there's so many things that can be addressed and ways that we can affect people's function and ability to live their life in a way that is fulfilling to them, to remain active. So we oftentimes, when we see a patient for a shoulder condition, we want to find out why they're coming in. And many of those patients, it's because of pain. And that's really why a lot of us went into this field, is so we could address pain and improve it. But sometimes it's not pain that brings them in. It might be weakness or stiffness. And those things can all affect their ability to perform daily activities, whether it be their job or their hobbies, or sometimes even sleep comfortably. Sometimes a sudden injury or trauma would bring them in, and that obviously would be a little bit different type of visit in the clinic. And these can be caused by many different things, not just trauma or injury, but sometimes overuse. Sometimes people joke that things like CrossFit or very aggressive, repetitive activities with the arm or body can lead to overuse injuries, things like CrossFit. Other times, things like genetics can play a role in the conditions that develop in the shoulder. And there is a genetic component of things like early shoulder arthritis and even rotator cuff problems. When the patients come in, after we understand what has brought them in and what is troubling them on their physical exam, a big part of that in the shoulder is evaluating their motion. How far can they reach in different areas? Do they have stiffness? And what hurts and where is their pain? And then oftentimes we move on to x-rays, and many people might minimize those or think that they're not as powerful as these more fancy or robust things like CT scans or MRIs. But x-rays, especially in the shoulder, are really quite critical. They can show us a lot of information and realistically with much less radiation than a CT would show. So x-rays are really very powerful and can make the diagnosis in and of themselves. This picture on the upper right is one that demonstrates arthritis because the normal shape of the shoulder has been altered. We can also use things like MRIs. Those give us very good pictures of cartilage and the rotator cuff tendons and muscles, and those would be utilized to demonstrate or illustrate when those other soft tissue structures have been injured. Ultrasound can also be really powerful, and those can be done in a different way. Patients, as you oftentimes know, have to lay flat for a period of time for an MRI, and that can be very uncomfortable. Ultrasounds can demonstrate some of the same information, but in a different way, and where a patient doesn't have to be positioned in an uncomfortable way to get that information. So the rotator cuff is 4 tendons and muscles. And most everyone knows someone who has had a rotator cuff problem. They're really quite common. And our management of those has been increasing. We did a study that found that from 96 to 2006, the number of rotator cuff repairs increased almost 150%. And we can fix those through the scope, through little incisions, and that increased by 560% in that same time period. But we don't always operate on them. Sometimes physical therapy is very effective in a lot of rotator cuff tear patients, and we're very grateful to our physical therapy colleagues for helping us treat these patients, because this is a really ideal way to address a lot of rotator cuff problems. Sometimes injections are used, and then in cases where the tear is of a particular nature or other treatments haven't worked, we can use surgical repair to fix the rotator cuff tendon tear. And these pictures are of arthroscopic images taken with instruments through little incisions to be able to restore more normal anatomy. Shoulder instability is a actually common problem. And as we mentioned with the golf ball, golf tee analogy, if you took a chunk out of the golf tee or the golf ball, the ball wouldn't stay on the tee very well. And likewise in the shoulder, if there's a bony injury on the ball or socket side, such as with these pictures, then we have to address that to restore the stability. The bottom picture there is one where we have put in sutures and anchors in surgery to be able to sew and repair a fracture injury to make the shoulder stable again. Similarly here, a picture of the shoulder on the top is demonstrating an area of bone loss, and that allowed the ball and socket, the shoulder, to dislocate frequently. And so we can restore that by putting bone and cartilage back into that defect from another area, and sometimes from a cadaver, to be able to restore a patient's function. Fractures in the shoulder are not uncommon. Sometimes they're very severe, like the one on the left, where the humerus has broken into a number of pieces. And those that would require a surgical treatment. Fractures don't always require surgery, and sometimes in the shoulder, a simple sling is a really effective tool to allow things to heal. Other times we use metal plates and screws, like the picture in the middle. And in some cases, we even have to do a joint replacement because of the severity of the fracture. So the last condition I'll mention is that of arthritis in the shoulder. And forgive me for using knee pictures, Dr. Arndt, but these pictures on the left is a very healthy joint with smooth, pearly cartilage. And then the one in the middle is showing a little bit of cartilage wear, where it's a little bit fuzzy. And then the one on the right, where we've actually lost cartilage and the bone is exposed. And that's what arthritis is, the loss of cartilage in the ball and socket joint. And that can happen for a number of reasons. Sometimes it just wears down over time, but it can happen from trauma. The picture on the bottom left is a normal shoulder, and we can see that there is space between the ball and the socket, and that space is healthy cartilage. When the space is gone, such as on the right side, there is no cartilage, and that is really more severe arthritis. Sometimes we can treat that with non-surgical measures like physical therapy or injections. But increasingly, when someone has complete loss of cartilage and they can't position their arm in space, they can't sleep well, and other treatments haven't helped them, we move on to a shoulder replacement. And that is increasingly common. Lots of people don't know that shoulder replacements can be done and can be very effective. From 2011 to 2017, that increased 100 to almost 200%, depending on which type of replacement in the shoulder you're looking at. And we have projected in some models that there will be up to another 200% of growth. So total shoulders are growing faster than hips and knees. And they can do very well. The expectation is that we make their pain better. And they oftentimes can move their arm in a way that they can return to golf or swimming, fishing, hiking, and tennis, many different things. And it's really a very satisfying thing to be able to return somebody to having a much better quality of life with less pain. It can take some time. That is the knock on shoulder surgery, is that the recovery can be a while. It's usually sometime in a sling, whether that's fractures or rotator cuffs or replacements. And biology takes a little bit of time. We can't speed it up necessarily, so it does take patience. And that's a process that we work through with our physical therapy colleagues while we care for these patients. Very briefly, at the end here, I'm going to talk about some of our innovation at the university in shoulder care. One of my passions is making these patients have a better experience if they have to have a surgery. And in working with our anesthesia colleagues, we've been able to intervene in ways that minimize their pain after an operation that historically might have caused them quite a bit of discomfort for a week or more. So by using different types of numbing medications, in nerve blocks around the time of surgery, we've been able to decrease how much narcotic they might have to take and really improve their experience after having a surgery. And that's really very, I would say, rewarding and a very positive thing, both for the patient and the physicians taking care of them. Additionally, we're also innovating and helping our patients to not have to stay in the hospital for surgeries. And so they can go home after even having a shoulder replacement. And we use additional technologies to plan how their replacement might be done, using CT scans to predict and plan what size and shape and positioning of the implant is going to provide them the best possible outcome. So there's a lot of innovation in this area. It's an exciting field, and we're really happy to be able to take care of patients in this way. Thank you.
Thank you, Alicia, for your enthusiasm about shoulder joint health. As you point out, the shoulder does serve to position the all-important hand in space, and as a hand surgeon, I too am passionate about its function. Our next presentation is by Dr. Brad Nelson. Dr. Nelson is a professor in the Department of Orthopedic Surgery. Dr. Nelson is the medical director for Gopher Athletics and the team physician for the Minnesota Wild Hockey. His clinical interests are in sports medicine. Brad, can you discuss with us some of your experiences in sports injury and prevention?
Yeah, thanks, Dr. Vennis. Can you hear me?
Yep, sounds good.
Yeah, good evening, everybody. Well, I'm very excited to be here. It's always great when somebody asks me to talk about hockey, which has kind of been a lifelong passion of mine. Let's see if I can. I don't have anything to disclose regarding this lecture, although I've been told that I should let the audience know that there are some injury pictures and videos. So I'll give you a little bit of a heads up. So who am I? Well, I'm an orthopedic sports medicine surgeon at the University of Minnesota, and I'm the medical director for Gopher Athletics. I'm a team physician for the Minnesota Wild, as well as the University of Minnesota, the men's hockey team, and some other teams. I'm a team physician for USA Hockey, and I'm the past president of our National Hockey League Team Physician Society. So what is a team physician? So the team physicians come in many forms. It's simply a medical professional who's dedicated to the care of athletes. Most often, it's an orthopedic surgeon or a primary care physician with additional training in sports medicine. At higher level athletics, that team physician also takes on the role of being a leader of a whole sports medicine team that may include athletic trainers, may include nutritionists, sports psychologists. We provide on-field or on-ice medical coverage during competition. We make decisions on clearance to participate and return to play. And then, of course, we care for injuries and illnesses that happen in athletes. So in terms of injury prevention, really, I think a lot of what team physicians do to prevent injuries happens in the off season. We have a number of organizations that care for athletes. A good example is in professional hockey, where the NHL Players Association, and the NHL Team Physicians Group partners on meetings to talk about player safety issues. The same thing happens at the NCAA and conference level, as well as with USA Hockey. We talk about medical standards. We use injury data like you see on the right, where we look at different injuries. We try to come up with ways to help prevent injuries. We talk about who should be part of the medical team. If you look at professional hockey right now, the medical team consists of orthopedic surgeons, primary care physicians, ER physicians, a dentist, an ENT physician. We don't quite have that robust of a team at the NCAA level, but we often have multiple physicians at games. We talk about pre-participation medical evaluations, where athletes have a preseason physical to determine their fitness to participate. We have lots of protocols. One that we spend a lot of time talking about is concussion protocols. And these discussions can lead to rule changes and equipment modifications. And I'll give you some examples. So one of the most common sources of injury, or the most common source of injury in hockey, is body checking. And we've made some changes over the years to try to reduce the number of injuries secondary to body checking. A good example is now in youth hockey and USA Hockey, body checking isn't allowed until age 14. In the NHL and the NCAA, we've increased penalties for head contact, which has been very helpful. Another really good example of a rule change that came up with collaboration was eliminating the touch-up for icing. So a player no longer has to touch the puck, which decreases contact with the end boards. For equipment modifications, I think the one that has been the most prominent is facial protection. And at the NCAA and youth level, the hockey players are required to wear a full face shield or a bubble. We've been able to get the NHL players and junior level players to wear a visor. I think the thing that's really come into focus lately is cut resistant equipment. We're doing a lot of research on improving cut resistant equipment. Neck protection is now mandated by USA Hockey. The professional league has now mandated neck protection for the AHL, and it's highly encouraged at the NHL level. And then one of the things that I've seen happen over the last few years is just the increased use of shot blockers on skates and the improved technology with shot blockers. So as we get ready to start a season, and so we can prevent injuries in our athletes, we do a fair amount of preparation. As I mentioned, we put the athletes through a pre-participation medical evaluation that includes their history, physical examinations, labs, EKG, baseline concussion testing. One of the things we pay a lot of attention to is an emergency action plan. You can see a demo of one of those up on your right for Mariucci Arena. And what we try to do is make sure that all the medical team is very familiar with how we're going to handle an on-ice emergency. And then we actually practice. And we do this at all of our levels where we practice spinal injuries on the ice. We practice a cardiac event on the ice. And that brings in some unique challenges trying to work as a team on a slippery surface. So fortunately, on-ice emergencies are rare, but they can happen, and preparation is the key. This is what I'm usually doing when I'm covering a game is, trying to get a little bit of work done, and then pretty quickly we can organize to handle an emergency. You can see the video on the right. It really only takes us a few seconds to have the EMTs on the ice, the entire medical team, to help with this athlete. We have well-staffed medical rooms. You can see on the bottom, that's an example of our medical room at the Excel. But probably most importantly is we use professionals who are used to dealing with emergencies out in the community. So we use St. Paul Fire at the Excel. We use our University of Minnesota EMT folks or Hennepin County EMT at the U. And these medical professionals can be very valuable in handling a true emergency. Fortunately, that's not what I spend most of my time doing. I spend most of my time dealing with a lower body injury or an upper body injury. And as you know, hockey has a bit of a secretive culture about injuries. You'll hear it in the media all the time that somebody had an upper body or a lower body injury. These two coaches here like it that way. I think it's kind of a tradition in hockey. So some common lower body injuries include hip and groin injuries, knee ligament injuries that could include an injury to the medial collateral ligament or the anterior cruciate ligament, high ankle sprain or a syndesmosis injury, and foot fractures. And we'll touch on a couple of these. So groin and hip, I think the most common groin injury is our simple groin pull, which is a muscle strain injury of the adductor. And it's common in hockey because hockey players' adductor muscles are much stronger than their abductors. These usually resolve with time and rehab. Rarely, even with severe groin injuries, do we need to treat them with surgery. They tend to improve without surgical treatment. For prevention, I think our strength and conditioning coaches have really done a good job coming up with dynamic warm-up programs and focusing on trying to get a muscle balance by improving abductor strength. This is one of the issues that we spend a lot of time dealing with in hockey players, and this is called a core muscle injury or a sports hernia. We might call it athletic pubalgia. It's common in hockey players. It's really secondary to chronic shear forces on the inguinal wall musculature that will result in tissue injury. It causes groin and lower abdominal pain. It can improve with rehab, but we are sometimes able to manage athletes over time non-surgically. But often this is something that requires a surgical repair at the end of the season, and it's a specialized hernia repair or a core muscle repair that usually requires about 8 to 12 weeks of recovery. The hip joint, I think the things that go together in the hip joint are hip labral tears. You can see on the drawing on top, the hip labrum is this circumferential cartilage rim that goes around the hip socket. Hip labral tears and femoral acetabular impingement, or FAI, go together. And the X-ray on the right shows a bump at the head and neck junction that hockey players get. And this is something we see really commonly in hockey players, and we think it's an overload injury over time. Really starts in our young players. It's most common in goaltenders, particularly now because goaltenders pretty much focus on the butterfly position, which puts some strain on the hip joint. Surgery may be required. We're often able to get an athlete through the season, but occasionally we have to do surgery where we remove the bump around the hip joint, as well as repair the labrum. And this surgery is successful, but it does take a long time to recover. So on to the knee. The most common knee ligament injury is a medial collateral ligament injury, and the MCL is the primary stabilizer on the medial aspect of the knee. It usually occurs with a knee to knee or a knee pinned against the board type mechanism, and we grade these injuries 1, 2, or 3 based on the degree of ligament disruption. Fortunately, medial collateral ligament injuries are usually treated non-surgically. The MCL will heal. It will heal because it is not an intra-articular ligament. There are times, if you look at the MRI at the bottom, the MCL right here looks like a bit of a window shade. Sometimes on distal significant injuries, the athlete will do better if we repair that ligament. But most often we do rehabilitation, the player wears a brace. We often will have them return to play in a brace to protect their knee. And this is one of those injuries that is a, kind of a 2 to 6 week injury based on the degree of ligament injury. The anterior cruciate ligament is an important knee stabilizer. This ligament is injured either through a non-contact or a contact injury. You can see in the video that is a player that actually sustained an ACL injury from that contact injury. ACL injuries are more common in sports like football or soccer, but they can happen in hockey. We make the diagnosis from the physical examination. You can see the video, that's called a Lockman test, and that knee is loose compared to the other side. And then we often get MRI scans, which will show a completely torn anterior cruciate ligament like the yellow arrow is demonstrating. So unfortunately, we haven't had the best luck treating anterior cruciate ligament injuries in athletes non-surgically. We tend to recommend surgical reconstruction, and we reconstruct the ACL with tissue that we get from the patient's own body or from a donor, but usually in a young athlete, it comes from their own knee. We are doing some investigating on ACL repair, and we are part of an NIH-funded trial where we're using a collagen sponge that's actually made from a cow to help the ACL heal. The ACL doesn't heal as well as the MCL because it lives inside the joint and it can't set up a healing clot. ACL surgery usually takes 7 to 9 months for an athlete to return to full competition. And what we published a paper looking at NHL players and how they fared after ACL surgery. And what we found is that they had a high rate of return, but their performance did decrease. And if you just take a quick glance at the table at the bottom, you can see that goals, assists, points all decreased compared to a control group after ACL reconstruction surgery. This is another problem in hockey. It's called a high ankle sprain or syndesmosis injury. And you can see the left skate on the player above has an external rotation contact injury, and you injure the syndesmosis. And the syndesmosis is a group of ligaments in the ankle that provide stability. And you make the diagnosis with physical examination, radiographs. The radiograph or x-ray, the ankle x-ray that's shown at the bottom, shows a widened space between the tibia and the fibula, indicative of a severe syndesmosis injury. And the MRI scan can help you look at each individual ligament and determine the injury pattern. Syndesmosis injuries or high ankle sprains are often treated non-surgically with a walking boot for a short period of time and then rehab. We have tried injections sometimes to try to accelerate the healing response, sometimes platelet-rich plasma. This injury does take a longer time to recover in hockey than other sports, and it's because the skating motion puts a lot of external rotation force across the ankle. And it takes a hockey player 4 to 6 weeks to recover from a high ankle sprain. Occasionally, if the syndesmosis injury is quite unstable, we'll recommend surgical stabilization. And you've probably heard this if you follow sports in the news. It's kind of got its own name now called the tightrope procedure, where we put stabilization suture from the fibula to the tibia. It stabilizes that syndesmotic joint and the ligaments will heal. So on to upper body injuries. We won't cover concussions, but we'll spend a little time on shoulder instability as well as AC joint injuries. So shoulder instability is the most common shoulder injury in hockey. And it's when the humeral head pops out of the socket. As Dr. Harrison mentioned, the shoulder socket is quite flat. It can come out and slip right back in. We call that a subluxation, or it can come completely out and require an athletic trainer or physician to pop it back into place. And the shoulder can come out either the front or the back, so you can have anterior instability or posterior instability. And almost always when the shoulder comes out, you're going to tear the labrum. So like the hip, the shoulder has a labrum. It's a cartilage rim that goes all the way around. And almost always when you have a shoulder dislocation, you tear the labrum. We call it a Bankart lesion after an orthopedic surgeon who actually didn't even describe it, but somehow got credit for it many years ago. The treatment for a shoulder dislocation is we tend to reduce these either on the field, on the ice, or in the training room. My favorite way to reduce a shoulder is actually just have the athlete go flat right on the training table. and put a little traction on their arm, and you get them to relax, and you can usually get it to reduce. Initially, the treatment is rehabilitation. We often can make it through the season. Our return to play criteria, the athlete has to have no pain. They need to have full range of motion and normal strength. And we'll often return them to play initially in a brace. This can be a little bit of a battle. Initially, athletes don't necessarily like to wear these, but I think they can be a little bit helpful when you're getting someone back early on after a shoulder dislocation. So I think for high-level athletes who have had a shoulder dislocation, they tend to do better if we fix the labrum and tighten the ligaments. And we can do this either arthroscopically or we can do it open. The video that's playing on front shows the labral tear. And we use suture anchors, as Dr. Harrison mentioned, to fix the labrum back to the shoulder socket, and it heals. The one thing that we're learning is that bone loss is a problem. If you look to the video at the bottom, this shoulder has lost a lot of bone on the front of the shoulder socket. As Dr. Harrison mentioned, it's like having part of your Gulf tee knocked off. And usually we have to replace this bone to make the shoulder stable, utilizing either some bone from the patient, that's called a Latarjet, or we can use donor tissue. Fortunately, shoulder surgery has a very high rate of return, and we don't seem to see the same diminished performance after shoulder procedures as we do after an ACL reconstruction. The final injury I'll talk about is acromioclavicular or AC joint injuries. These can happen with a direct blow from a player to the boards, to the ice, or to another player. And what usually happens is you injure the AC and the CC ligaments, and the diagnosis is made by a combination of physical examination and radiographs. And you can see the deformity of the right shoulder on the player down below. And then the x-ray shows that the clavicle bone is way up in the air, and that's indicative of a fairly significant injury to the ligaments. Again, fortunately for this injury, the treatment is almost always non-surgical, particularly in a hockey player. It usually takes time and rehabilitation. I'll usually tell our coaching staff if it's a grade 1 injury, we'll say 1 to 2 weeks. Grade 2 is 2 to 4 weeks, and a grade 3 AC injury may take 4 to 6 weeks. And we try to come up with a way to protect the AC joint when an athlete returns to play. You can see the padding that our athletic trainers have come up with on top. This is one of the places as a team physician that you can feel comfortable putting a little numbing medicine in the joint for an athlete to return to play. It can be quite helpful. And that's all I have.
Well, that's great. Thank you, Brad, for sharing your experience as a hockey team physician. That certainly is a sport that's near and dear for most all Minnesotans, and appreciated. Now it's my pleasure to introduce our third speaker, Dr. Elizabeth Arndt. Dr. Arndt is a professor and vice chair of clinical affairs, as well as the MHealth service line leader in our Department of Orthopedic Surgery. She is an orthopedic surgeon with expertise in sports medicine and serves as the Gopher team physician for women's basketball and volleyball. Her care and clinical interests are focused on treatment of the female athlete, and particularly injury of the kneecap or patellofemoral joint. Liza, can you discuss with us the female athlete and knee concerns?
I would love to. Thank you for this opportunity. So I'm going to take a little bit of a different approach, although we've all sort of talked a little bit about the injuries and their prevention. So I have no disclosures that are related to this program. So let me see if I can get this smaller here. So a big focus is ACL injuries in females. What does sex have to do with it? And rather than that, not sure why this isn't advancing. Okay, sorry. So we all know that our basketball team, our basketball has been a sport that we see more ACL injuries, and we've come a long way with caring for these injuries, and we've come a long way with being more expert in terms of the athleticism of our female athletes. So rather than ask, are females more at risk, what we want to ask is why? Why are females more at risk? And we're going to go through a little bit of the logic behind here. The seminal article really was approximately early 90s, and we'll talk just slightly about that. And there's just been a plethora of articles that are trying to understand that. I, being a female athlete, don't want to blame it on our sex, because I think that our hormones are very critical to so many other parts of what we do. So this actually came, this concept of women being more at risk for ACLs actually came when I first came as a team physician. And I had the opportunity, and we actually had way more ACL injuries in our women basketball teams than the men's basketball team. And at that time, I was really the team physician over both of them, the orthopedic team physician. I also had the privilege of serving on the NCAA Safeguards Committee. And one of the things they had this injury surveillance system. And so what I did is I used that as a core, and I kind of arbitrarily picked the sports of soccer and basketball because they were two sports that men and women played. They played fairly similarly with similar rules, and they actually were counted in the NCAA system. At that time, we did not have women hockey, and even so, there's contact versus non-contact. We didn't, lacrosse is contact versus non-contact. Gymnastics is not similar in their apparatus between men and women. So rather arbitrarily, I picked soccer and basketball. And this shows you the 5-year data. I'm sorry, this shows you the 13-year data on looking at females up above and their ACL injury rate and men below. So there is almost a threefold difference. And I looked at the first 5 years, and then we carried it out through the first 13 years. So this is the rate in soccer. This is the rate in basketball. What really surprised me is that if you think about Title IX, which was 1975, and then sort of gender equity that the NCAA rolled out around the early 90s. And we all see this, this explosion of sports in our high school. The women are coming in, better athletes, better coached, more team play. And yet the injury rate stayed about the same, which I must say surprised me over time. And so again, this data showed that there was no significant difference in the rate of ACL injuries in men or women over that 15-year period. So this led to a bunch of consensus conference and committee statements, and I'm just showing you a few of these, but you can see that they go on through the years. And I'm going to just highlight a few things. I'm throwing up two things that have been talked about, but I'm not going to concentrate on them. One is hormones, and we really have not had definitive evidence that hormones play a role. And there are isolated studies that say that during a certain part of our menstrual cycle, we may have more laxity, but it's never really proven two things. One, does that increase your risk? And two, why is the knee so at risk? I mean, what's that poor little ACL doing? And why would estrogens, which is so important for the health of so many other parts of our body, why would that musculoskeletal system be at risk for injury? Genetics does play a role, but again, we don't know enough about it to speak about it. And we have other things I'd like to share with you tonight. And the first is really, or I would say the most important, is the neuromuscular mechanisms. And the reason why this is important is because it's changeable. It is something that we can affect. And let's see if we can talk a little bit about that. So we've gone into these ACL prevention programs because we believe if you enhance the body control while you do a sport, if we can control that limb rotation underneath the cylinder of your body, particularly in jump landing, squatting mechanisms, and deceleration, we can decrease the risk of serious knee injuries. And the number one injury, serious knee injury, is the ACL. So again, what we're trying to do is control limb rotation under the pelvis, land with a flex knee and hip, and plant and pivot with the foot kind of inside that vertical cylinder of your body. Don't be reaching outside your body with your limb, and try to play in control. So these are two faulty movement patterns. The one on your left is the more common one. And the pelvis, so as you're doing a partial squat, single leg, your pelvis tilts, your knee sort of turns inward, or something we call adduction, and you end up having this out of balance or out of sequence body movement. And we call this the dynamic valgus knee or the functional valgus knee. But another common one that we see, particularly in our younger athletes, females more than males, and particularly in patellofemoral, is that we don't have any good squat mechanics. They're not using their butt muscles at all. And so what happens when you try to do a single leg squat, you end up having your knee having a forward inclination over your toes. And this actually is painful for the patellofemoral joint, and it's hard to do. You're not very balanced. So again, on our left is a coronal or frontal plane, and on our right is a sagittal or side plane. And then here I'm showing both a male and a female, kind of with these incredibly funky body movements. Now, this is sort of demonstrating in our physical therapy setting, but you can imagine if they're doing this while they're trying to do a sport, that they could be at risk for an injury. So this again is in that coronal plane. But again, it's also true in the sagittal plane. So you can see that it's really hard to execute. And you can imagine that if you are doing this on a regular basis, that when you're coming down landing from a jump, you might not be able to balance your body. And then, of course, you're looking at a ball or something else coming at you. So these are two body movement patterns that we pay particular attention to when we're trying to rehabilitate an injury. So again, there's been many neuromuscular intervention programs, significant number in our literature, and most of them have shown that they decrease ACL injury risk. So what's interesting is that the programs with the greatest success are ones that increase performance and decrease injury. And I'm just showing this volleyball because I found it a little bit interesting that approximately 1995, Tim Hewitt, who was then with Cincinnati Children, did a study and looked at trying to recruit teams, and he was recruiting basketball, volleyball, and soccer. And he was doing, half with the intervention, half not. And all of the volleyball pro players wanted to go into the program because they believed that it increased vertical jump. And the basketball players wanted to go in because they believed it increased vertical jump, and the soccer players didn't care so much. And so we had a mismatch in the kinds of athletes they were looking at. And so most of the coaches agreed to do it because they believed that it increased performance. Most kids these age, and maybe all athletes, they don't really think about themselves as getting injured. But if you can tell them that they can increase performance, then they get interested. So what we don't know about in ACL injury intervention programs is we do know that they work, but we know that they're transient. We don't really know what screening tools might work, on the field. And there's programs that do work on the field, but again, we don't have a good field assessment and screening tools that target the time spent. But I think the biggest issue is we really don't know what best age to target screening. The initial screening was all done in college age students because we could recruit them more easily than we could teenagers, and that might be too late. And then the question is the idea of recidivism. When do you imprint it? And this may be true of all things that we learn, both with our brain and with our body. And so we don't really know all those answers. And is it different for the pediatric population? So again, age group, young versus pre-puberty, feedback mechanisms. Do you need a trained personnel? Can a video or teammate help? Timing of the season, how much, how long, preseason, in season, and this recidivism. Can we imprint this and how? I'm going to go a little bit into anatomy because I will say early in my career, the full focus was on neuromuscular, which is great, and it still is ongoing. But anatomy does play a role. And interestingly, when we were kind of collecting some of these injury mechanisms, there are people in college that were on their fifth ACL, which means like 3 on one knee, 2 on the other. And so you have to kind of think, why are some people more at risk? So the intercondylar notch, which is where the ACL lives, this little circular kind of half circle, that was a big focus. And we don't really now think it plays such a role. It may be a little narrower in some, maybe the ACL that is smaller and narrower notches, but we don't feel that this is really the core of the anatomy of the anatomic risk. The thing that has come most into play now is the tibia shape is probably the most important, and the femoral rollback has something to play. So the tibia, which is your lower leg bone, has a certain slope. And let me see if I can get back. Yep. has a certain slope, and it tends to be about 10 degrees, maybe, 5 to 10 degrees normally. If it's over 15, 12 to 15, we think that it may play a role in that rollback of the ACL, and that might be at risk for injury. And you can also see, in addition to the slope, you have a different length of the medial versus lateral side. And then if you're looking at rotation, you have a different rotation as well. So again, lateral condyle is rather flat or convex. The medial condyle is concave. And with ACL injuries, it's that lateral side that's more mobile. And you can see, kind of talking again about the shoulder, that we really don't have a good way to contain this. So that's what we've been thinking about lately. So going back to the slope, we've known for a while that there is an increase in anterior tibial slant translation when there is a 6 millimeter increase in anterior slope. And we've known this, we just didn't quite know how to execute that in a way that was preventative for our young athletes. And so we do know that there is an anatomic risk, and we do know that it has something to do with tibial rotation, has something to do with tibial slope, and maybe the length and convexity of the tibial plateau. And if you have one or more of these, you're at high risk for ACL injury. And of these issues, the tibial slope is something that we can affect with surgery. So the way that we think about ACL risk now is that there are definitely anatomic risk factors, not so sure about hormonal, and we do know that the neuromuscular factors do play a role, and maybe in some combination, they are at high risk for ACL injuries. So again, we have all these potential factors. Is sex one of them? I would like to say no. And I think that we need to applaud our differences. So again, we're going to go on to lateral patellar dislocations. So you did hear a little bit about this by Mark Tompkins if you were present at our last week's mini medical school. But if you look at ACL, I'm sorry, I'm going back. If you're looking at lateral patellar dislocations, we do know that they span the age groups. But as you can see, this is a study we did here at the University of Minnesota. You can see that they cluster in the adolescent age group. And this was a fairly large cohort of 238 knees. Now, if we take that age group 9 to 18, you can see that they peak at different ages, but across this age group, men and women are about equal. And if you look at this, women peak a little bit earlier than men. And this is almost identical to what we're seeing with ACL injuries. We have the men having a little bit more injuries as they go into their 20s. Girls and females have a little bit more injuries in their pre-adolescent and early adolescent years. And so we do know that is our females more at risk? What's interesting is if you look at first-time patella dislocations, I'm just going to go back to this slide. So first time you dislocate a patella, the sex distribution is nearly identical in almost every study that you look at. But then if you go to the literature and you say, who do we operate on? These are just random papers that I picked out. I'm trying to look more into this in some kind of more concrete way. But you can see 224 patients, 73% females, 99, 77% female, 40 patients, 70% female, 68, 75. Now, there are other reasons you can be saying that you operate on more women than men, but I do think that women are more at risk for the kinds of anatomic features that might make you more at risk for recurrent patella dislocations. So again, we come back to anatomy. And so again, I think you heard from Dr. Tompkins that there are anatomic risk factors. This was a very seminal study that was done by the Lyon group in France, and they found that there were 4 radiographic or anatomic factors, and one had to do with the shape of the trochlea or groove. One had to do with the something we call the Q vector, or what shape your muscle angle is as it goes from the hip to the tibia. One is the patella height, and the other is patella tilt. And they found that this was highly associated with people who had recurrent patella instability. So we did a systematic review, and we did look at a lot of studies. And even though we know that these are risk factors, it's really hard to be very precise about, like, is there a threshold that if you cross that threshold, you're at high risk, and if you don't, you're at low risk. And as with most of our risk factors, the combination of them isn't so good. And so here we just talked about those 4 risk factors, and here are some studies that looked at the number of risk factors. If you had no risk factors, your risk of recurrence is very low. One risk factor gets a little higher, and if you go all the way over here to 3 and 4, they move across almost in a 25% increase, so that if you have all risk factors, your risk of redislocation is quite high. And the risk factors were not only the ones I showed, but also open growth plates, and age. So age seems to have an important part to play. The younger you are, the more likely you are to have open growth plates, and the more likely you are to redislocate if you are unfortunate enough to have your first dislocation in that young age group. So what I'm trying to emphasize here is that we oftentimes think of injuries as a little bit of bad luck. I'm not saying that that's not true. It's always a little bit of bad luck, but there are features that we can control, and those are those neuromuscular features. And there are things that really we can't control. And I think that anatomy plays a role in ACLs injuries, anatomy plays a role in patellofemoral injuries. So there's another factor that we call trochlear dysplasia. Again, trochlea is the fancy name for the groove. Dysplasia means not well formed. And this is another factor that in kneecap arthritis, trochlear dysplasia plays a high prevalence. So if you look at a big cohort of people with isolated kneecap arthritis, the vast majority of them have this trochlear dysplasia. But sadly, most of them are females. And so I do think that there is a correlation between anatomy and injuries and illnesses and diseases of the kneecap joint. And I think that the high grade anatomic issues are more prevalent in women. That's still to be completely determined, but we certainly have enough information leading towards that issue. So again, going back to these faulty movement patterns, these are equally prevalent in patellofemoral problems. So again, I think that with neuromuscular mechanisms, it's important to incorporate into operative and non-operative treatment, especially in our youth. A lot of orthopedic surgeons say, "Yeah, I believe in these neuromuscular things, but I don't have access to a program, and I don't see the kids before they get injured." But we do have a responsibility once a patella dislocation comes into our clinics, once an ACL injury comes into our clinic, to incorporate these neuromuscular mechanisms into our post-op treatments as well as our non-operative treatment of these knee conditions, especially in our youth. Thank you for your attention.
Thank you, Liza. We really appreciate that important information about knee injuries and especially prevention, and particularly in the female athlete. Maybe we'll start first with you, Liza. We're going to talk about some questions and answers that have come up submitted by our attendees. And before we start that, as a reminder, you can submit your questions to our panelists using the Q&A box, which is found by clicking on the Q&A button at the bottom of your Zoom screen. Let me also remind you that each of the panelists tonight and in all 3 sessions of the mini med school are practicing orthopedic surgeons. So if you have specific patient care questions, I will defer and remind you that clinic appointments can be made with any of these physicians to address individual concerns. But we do have some very good general questions. So let's start first. Liza, can we be enlightened as to why we see more college football players, especially in the front lines, wearing braces on their knees during games? Is this a preventative measure based on risk factors, or are we seeing a reduction in injuries? May we know who is making these devices? It looks helpful. Thank you.
I think Brad has equal amount of insight into this. There was a big push to wear the braces to prevent MCL injuries. And it's a pretty complicated answer, but it really depends on the shape of your knee. And sometimes the braces are helpful and sometimes they're hurtful. And I think in the long run, they have not shown enough effect to be added value to put it on as a preventative mode. I think a lot of players wear it because they've had knee injuries in the past. How would you answer that, Brad?
Yeah, I think, we use ACL braces in football players that are in positions of high risk, like internal line, but it's really to prevent medial collateral ligament injuries. The data on ACL injuries, of a brace preventing an ACL injury, the data is not very good, as you mentioned, Liz. And I mean, maybe there is a little bit of data in downhill skiing, but even that, those studies aren't great. But I think specifically to interior line football players, we're using those braces to prevent MCL injuries primarily. They get rolled up on a lot, and that's the mechanism of injury.
Great. Brad, we also have a question for you about if you could talk a little bit more about becoming a team physician. Specifically, they ask, how do you choose what levels of teams to work with and what additional training is needed for an orthopedic surgeon to specialize in sports medicine?
Yeah, it's a good question. So, for an orthopedic surgeon to be a team physician, you usually do a sports medicine fellowship. And during that fellowship, you learn lots of arthroscopic skills, taking care of knee and shoulder injuries. But most sports fellowships will have an experience where you will work as a team physician, either at the high school, college, or pro level. So every team physician taking care of a professional sports team, most team physicians that are taking care of Division I programs have a sports fellowship and a certification in sports medicine. And then in terms of getting to take care of college and pro teams, it's really a long process. I mean, you kind of start, usually working with somebody who's more experienced. I've been very fortunate in my career to have great mentors, Dr. Arndt here at the University of Minnesota, Joel Boyd, who has worked with me with the Wild for years. And it really is a long on-the-job training program to be a good team physician.
Well, thank you, Brad. I think we'll go back, Alicia, to you. And you had mentioned about the study that you did looking at the increase in rotator cuff repairs. Mm-hmm. This listener asked, why do you think there has been such a dramatic increase in rotator cuff repair?
Yeah, so I would say I don't think it's necessarily that there are that many more tears happening, although activities and repetitive use and certainly some sports might slightly increase that risk. I think it's really more that we have, as tools develop to treat them, and as surgeons become more facile with those treatment options, then the actual treatment numbers increase. Total shoulder replacements have been around since, the first one was actually designed in 1890, and they became much more common in the 1970s. But their dramatic increase, I think, is secondary to people really having more knowledge and experience with the surgical procedure itself and seeing the good outcomes, and then more of them are done. So same for, I would say, total shoulders and rotator cuff repairs.
Yeah, certainly we have seen a lot more success with surgery, which success breeds success and more. We also have a question that you may want to answer, Alicia. And in your experience, how do former high-level athletes fare at an older age of 50 plus when they've had lots of things like, and specifically shoulder instability, but other injuries? Maybe some of our other panelists can remark on that as well. During their playing days in college or professional sports.
Yeah, at least in the shoulder, an instability episode alone, having a dislocation doesn't necessarily mean a person will have arthritis. But if they have documented cartilage injuries that are more significant, and particularly if they have a number of repetitive dislocations, having instability events over and over again, that causes damage to the cartilage. And then they are more likely to develop progression of that, leading to much more severe arthritis in the future. But not every injury means that they're going to be limited as they age. Someone asked how to stay healthy. I think in general, having good bone health, staying active, strength training, cross training, continuing to move and stay strong. And I'll defer to my wonderful senior partners about their thoughts in that area too.
Well, I will add one thing. If you look back to the Surgeon General report on physical fitness and sport, it was, I think, 1994. They identified 3 things to work on as you age. And it's sort of global, but it's flexibility, strength, and balance. And I think that if you kind of look at those 3, as something that you move forward with. I think probably we forget about balance until we have trouble with it. But I do think that all along, it's really strength, flexibility, and balance, and that there's lots more information that goes into that. But that really came out of the Surgeon General report in 1994, I think it came out.
Any other comments, Brad?
Well, I would say that there are some things that we do to our bodies that do, I think, end up causing some issues as you get a little bit older. I think if you tear your anterior cruciate ligament, I do think that whether you have surgery or not, you have a higher chance of developing arthritis in that knee compared to an uninjured knee. And so I think uh, a lot of times we'll see athletes 20 or 30 years later who had their ACL surgery done. It was quite effective. They got back to all their activities, and then they start developing some osteoarthritis or in the shoulder. If you spend a lot of time as a throwing athlete, you may end up having some issues with rotator cuff injury or labral injuries. I think, though, to be honest, as a sports medicine person, I think those injuries probably are not near as significant as the health concerns from kind of a sedentary lifestyle.
And maybe we can follow up on that a little bit. And Liza, on your comments about strength, flexibility, and balance, this attendee says, what is the best tip you can give an athlete to help athletes age healthily? For example, strength training, physical therapy, mixing up the sports we do. What would be your best tip?
Well, when I learn it, I will start to practice it. I do think that we have to be mindful of overuse for sure. And I think that's true of every age group. I don't think we can speak knowledgeably at this point in time of whether sports specialization in early age is helpful or hurtful. It's an area of intense scrutiny right now. And maybe we can have commentary by our other panelists. But even within a sport, within a single sport, I think you can clearly overdo it. And not only we are talking about MSK injuries, so musculoskeletal injuries, but I also think that there's a mental drain as well. So I think that mixing it up is important. And I was just trying to answer one of the questions. I think we think too much that strength is the answer for everything. As three women, an orthopedic surgeon, I can tell you that we know that if you know how to do something, you use your body mechanics to the best advantage of perhaps limited strength compared to perhaps our male colleagues. But you have to know how to do things properly. You wouldn't be hitting a tennis racket or a golf ball and say strength alone is what matters. And so I think that we have to learn how to move our bodies through space correctly. So for a young athlete, I would say learn proper mechanics in a sport. And for the older athlete, if you're going to take something on, learn the proper mechanics of the sport as a tip. And I think that be mindful of overuse. Listen to your body. I think your body's still the smartest tool that we have.
All right, we have an interesting question from one of our other attendees, and that's for all three of our panelists. What has been your most challenging case? Can we start with you, Alicia? What's been your most challenging case? HIPAA compliant.
Of course, yeah. I think at the University of Minnesota, we tend to see a lot of referrals for complex problems, patients who've had lots of surgeries already. And so I would say my most challenging procedures are those where a person has had a number of surgeries for something, whether it be a fracture and that fracture is not healing and they've already had it fixed a couple of times. Sometimes it's because the biology just isn't there to help the bone heal, or it's a joint replacement that has worn out and needs to be redone. But I'm fortunate to have trained with people that taught me to take on those cases. And I think all of, the four of us, that's just a part of our practice, taking on difficult cases. So I think in general, ones where patients have had multiple surgeries.
And Brad?
Yeah, I would say the thing that's been most challenging for me is probably cartilage problems in really young people. There's a problem that we kind of specialize at the U called osteochondritis dissecans, where the bone beneath the cartilage will die and the cartilage will separate. And if the athlete's young and has open growth plates, you can try to get it to heal by just taking them out of sports, but no kid wants to come out of sports. The parents don't want the kid to come out of sports, and then if it doesn't heal, you're operating on young kids, and they can have these big cartilage problems in their knee, and it can really sort of take away a lot of their youth by recovering from these surgeries. They miss sports in high school. It's probably one of my most challenging things I take care of.
Yeah, it certainly outlines an unsolved problem. Liza, what's yours?
Well, I'd have to echo what Brad said about cartilage injuries in a young person, and certainly there's enough of them in patellofemoral instability. But I'm going to answer the question a bit differently. I think the most painful case that I can say, I mean, we are used to dealing with tough problems, and I will say as orthopedists, we help a lot of people, and that is extremely rewarding. But I think the most challenging or the most painful thing for me is dealing with pain, because they come to us and they feel that we have the answers for everything, and there are a lot of people that have pain that we don't understand. We don't understand where it's coming from, and that's true certainly with anterior knee pain. The parents they're oftentimes kids, and the parents expect more of this. They expect medicine to have the answer, and I think that that's very challenging. And so I think that when you can't solve the problem, or you know what the problem is, but it happens to be not solvable with surgery, I think that's a very hard thing, because as physicians, we're used to having the answers, and we want to help people. And I think those situations where we really can't help people is where I go home feeling sad instead of feeling, inspired. So
Yeah, it certainly makes it tough. One of the things we have been really successful in is ACL surgery, and we have one attendee who asks both Dr. Arndt and Dr. Nelson, do you favor a graft for ACL, and what factors come into play when selecting the graft type? They both smile.
Well, yeah, I smile because you can certainly get a group of sports medicine docs sitting around having a beer, and they can argue about this to the wee hours of the morning. I think there are a couple of things that are sort of decided. Donor tissue in young active people has an unacceptable failure rate. So we've tended to move.
meaning cadaver graft.
Oh, yeah, cadaver graft. So a cadaver graft. We've moved away from cadaver grafts in young people. I think as you get a little older, it's actually completely fine. I think there's probably enough evidence for me that in the highest level athletes that a patellar tendon graft still has the lowest failure rate. So that's the graft I tend to favor in my high school, college, and pro athletes. I don't know what you think, Liza.
I would answer it I think that if a surgeon always does the same thing and always uses the same graft, they're probably not keeping up with the literature. And so it's really, I mean, a lot of medicine, it comes down to patient specificity. And so I think it has to be, a patient-informed decision. But don't go to the person or don't go to one doctor because they do one graft and another doctor does another graft. It should be a shared decision, and they should be able to tell you the pros and cons of the different grafts.
Yeah, that's a great point. All right, we get another attendee who says, how likely is it to develop arthritis if you are not an athlete? And how does this occur? Do you want to take the first stab at that, Liza?
Well, it's so funny because I was thinking about this anatomy question, and I showed you how anatomy plays a role in ACL injuries. Anatomy plays a role in patellofemoral dislocations. You probably have some shoulder issues you can talk about, Alicia, where anatomy plays a role, and Anne with the hand. We used to think that osteoarthritis was sort of an unknown etiology. We know that load plays a role, and I'm talking about osteoarthritis or perhaps age-related arthritis as opposed to like rheumatoid arthritis. But the more we know about things, the more that we feel that it's a strong combination of genetics. Well, it is genetics. And so it's a combination of the genetics of your anatomy, the blueprint that you were born, your genetic blueprint that you were born with. And then I think that there is something to say about the health of the cartilage that I think plays a genetic role. But I do think that the best thing to do I'm not sure we can prevent arthritis. I mean, there are a lot of people who have arthritis because their parents have arthritis, and we didn't choose our parents very wisely. But I think that what we can do the best is to stay fit for sure, and then we can listen to our bodies as we move through space, and that could be whether you're a laborer or whether you're an athlete. I know laborers, get paid a lot for what they do, but the reason you get paid a lot for what you do is because you expend your body. So I think that we see overuse injuries and pushing to the max as much in our laborers or anybody that does repetitive work, and a lot of it is because they need the money or they're talented at a certain situation, but they have just as much risk for overuse injuries of the muscles and tendons and the joint. And probably arthritis represents the ultimate overuse injury of joint loading.
Great,
I would agree with Dr. Arndt. I think she makes all of those points are really important, and I would agree with each one of them. And I think they're true for the shoulder as well as for the knee and for the hip. But I would highlight the point that she says it's important to keep moving because some patients we've all seen patients who have arthritic changes on their x-rays, but they're doing very well. So I would tell people that just because you might develop arthritis, it doesn't mean that you can't remain functional, active, and it doesn't mean you have to get a joint replacement. I mean, we're surgeons. We like to operate on people to make them better. I'm happy to do shoulder replacements when that's the right answer. It's not always necessary. So staying healthy, and I think in this case, some degree of strength is helpful when you do it in the right way, and it can keep you active, and it can actually keep you from a joint replacement in some cases, even though you have arthritis.
Yeah, certainly we have the adage that we treat the patient and not the x-ray, because there certainly are people that can have pretty significant x-rays, but have very, very high function. I have one here specifically for you, Dr. Harrison, and a surgical technique. What are the long-term side effects of open acromioplasty? I think they're not being done anymore. Does this predispose to arthritis?
I would say it doesn't seem to be associated with arthritis. It isn't done as much anymore because a lot of open techniques aren't done as much anymore. When you can do certain things through little 1 centimeter incisions, you don't want to have to make a larger incision. So for a lot of cases, we don't do them open because we do them arthroscopically. Acromioplasty is another area where shoulder surgeons could stay up into the wee hours arguing about it. We argue about a lot of things and we debate. And this is an area I would say of ongoing study. Open acromioplasty, however, is something I think is very rarely done anymore.
Great. And then I had a question for our ACL doctors, if I can find it here. Is there a number of ACL injuries that you recommend an athlete to medically retire? Are you able to successfully help them with surgery and have them return to play, or is there an upper limit on that?
Yeah, I'm not sure there is an upper limit. I do think, one of the things I do as my job as medical director for Gopher Athletics is to have some honest conversations with our athletes. And we've had athletes come in who had multiple surgeries in high school, and then they have a re-injury here at the university. And I think we've developed techniques where we can make the knee stable, improve function. I'm not sure it's always so wise for them to go back to high-level Division I sports. So I'm not sure there's a number per se, but I do think one of our roles, Dr. Arndt's roles, is to have a conversation with the patient about some of the risks that you're going to accept by continuing to participate in high-level athletics.
And this question kind of dovetails with that. Maybe you can add to this, Liza. How are weight-bearing status and return to play determined? Are they evidence-based or experience-based? Some protocols vary when they present to PT.
This could be a longer answer, but in medicine, you can divide things into two big categories. One is temporally based healing, and one is functional based healing. The easy example I can give is a fracture. A fracture has to heal, and you have to give certain time to heal, and depending on where the fracture is and how you fix it, but it is a temporal thing. You can't necessarily speed it up. So those kinds of protocols are time based. Many of our protocols are functional based, which means it depends on strength, motion, and your pain level. And more, and once you get past that time based PT limit, then you go into that functional one. And so, there could be a debate, like with an ACL, like when can you go into that functional based situation? When is it healed enough? I don't know if we really even know that answer right now, but we're making it longer than we thought. I mean, certainly when I first started, 3 to 6 month return was pretty common, and the sooner you return to a sport, the better you were as an athlete, and the better you were as a surgeon. And now, if you're a good surgeon, you're giving the proper advice to kids, and now it's really more like 6, 9, 12 months. But some of that's based on what we know about healing and then what we know about function, and so they're not interchangeable. So.
And to piggyback on that, we have a question. Does Dr. Nelson get pushback on treatments due to athletes just wanting to play? And do the players downplay their injuries?
Yeah, I would say there's definitely an art of being a sports medicine physician. I mean, we have athletes that want to play and really shouldn't. It could have some significant long-term health consequences, and we have to put our foot down. And then there are times where it's a bit of a negotiating thing where you want the athlete to get back and get back safely so they don't have a re-injury. So I think most of the times it's a kind of a team approach between the athletic trainer and the doc. I think one of the things that I've learned over my career is the value of the athletic trainer who's around that athlete all the time. They really can give you a good sense of where the athlete's at with their injury recovery. But there have been times where I've had to put my foot down, and we've had to medically disqualify athletes from participating at the university, or we've just had to hold them out of competition because it's not safe.
Speaking of safety, here's another question for you, Brad. Where do you see fighting going in hockey in the future? Does fighting prevent excessive dirty hits in the game, or does that outweigh the risk involved in the fights?
That's a really good question. And I can just tell you what, Bill Daly, the assistant GM of the NHL, has said they like where fighting is at in the NHL right now, and it's down dramatically. So the number of fights has gone down dramatically. They think it's at about a level where it's serving its function as being a deterrent to dirty hits, but not resulting in the same injury rate that we had in the 70s and 80s. There are certainly some parts of fighting that are high. The risk of concussion in a fight is relatively high. It's such an uncontrolled situation. I think we've done a pretty good job of reducing fighting at the lower levels. It's not common at all in college hockey. The junior hockey level has really tried to reduce fighting in their leagues as well. I doubt that fighting will go away in hockey all the way, but I think there'll be a gradual decrease in fights, partly because no team really, there are very few teams that can put a player on their roster on the ice who is just a fighter. So, we've just seen this increased skill level, and, there are definitely players on a team that are kind of their physical players and their enforcers, but they're not like the players, even of 15, 20 years ago who can barely skate and are only on the team to fight. That doesn't exist as much anymore.
So could I ask Alicia, who is every bit of a hockey doc as Brad is, she does only women, at least as a team physician. Do you think that it is the difference between the sexes, or do you think that it has something to do with that the hockey allows checking and at least on paper women don't allow checking? And so do you think if we took checking out of the sport, is where I'm getting, that would help things?
Well, I would say, first of all, I think Brad, his experience in hockey is vastly superior to mine. But I will say, and I think we've talked about this in recent years, especially in the last year, women's hockey is becoming faster. There is more physicality than there was even 5 years ago, I think, and certainly 10 years ago. The skill level is just accelerating. It's still not the same as men's hockey. There are different rules. I think there is talk about what is or isn't going to be allowed in women's hockey in the coming years. I don't know. Those are discussions that are certainly not ones I'm sitting in. But the women are stronger and faster, and their game is changing, and I would say becoming more physical.
Yeah. I would say if you've ever watched the US team play the Canadian team in women's hockey, it is not much different than an NHL game. I think that the physical contact, skill level's super high, the physical contact's high. And I have a video, I didn't show it in my lecture. I have a video from a few years ago where Team USA and Team Canada women's teams got in a bench clearing brawl. Looks like an NHL game. So I'm not sure sex makes a difference, Liza. It might be the personality of a hockey player.
Could be.
All right, I think we will wrap it up with one last question. And I think we'll put this one to you, Alicia, because I think this has been brought up a couple different times. This is someone asking about supraspinatus tear, so rotator cuff tear. Can PT be successful or as a long-term solution, or will there eventually need to be a surgical intervention? What's the data on that?
It's a good question. There's a lot of data, still some questions. I would say it depends. Depends on a number of factors, and not all rotator cuff tears are equal, even ones only involving the supraspinatus. Ones that happen from trauma, like someone has a completely normal shoulder and then say they have a bike accident or they fall down a flight of stairs and they have a rotator cuff tear. We know from data that those do better if we fix them. Tears that, however, happen just over time due to tendon degeneration, which are the more common type of rotator cuff tear, can absolutely do well with physical therapy. Some do not. But there is a certainly acceptable and I would say evidence-based support for rotator cuff tears that aren't from an actual fall specific traumatic event to be treated first with physical therapy. If a patient doesn't respond to a course of physical therapy, then surgery is usually discussed.
All right. So with that, I would like to thank our panelists today for your time and for sharing your insights into athletic injuries and prevention. I've enjoyed our discussion here. We would also like to thank you, our participants in the MIDI Medical School, for joining us today. We did have 47 questions today, so we weren't able to get to all of them, but hopefully we touched on each of the topics. And we will be sending out follow-up regarding the question and answer as well as the recording. We hope to see you next week for our third mini medical school session that will be on innovations in geriatric bone health and joint care. This will be at the same time next Wednesday from 5 to 6:30 p.m. And we have an amazing group of University of Minnesota Department of Orthopedic Surgery experts who will discuss the latest approaches to preventing osteoporosis and for managing arthritis. So thank you very much and have a great night.